I'm very happy to be here and to be addressing all of you. And sort of as a preamble to this, I have come from a family of physicians where I am the only hematologist amongst many cardiologists. And I have been belittled many times as the less important of the specialties that happens to be represented at the Thanksgiving table. But we have had a lot of discussions between us all about sort of the relationships between cardiac disease and myeloproliferative disorders. Another story is my very first patient that I ever had as an attending when I was at Cornell was a man who was in his 40s who presented to me with a hematocrit of 16. And he was very, very, very red and had not been feeling well. So I gave him a phlebotomy in clinic and put him on hydroxyurea, and 24 hours later, he had a massive heart attack and was in the emergency room at Weill Cornell. I could not sleep for 3 nights after that. We worked really hard to sort of make him better, and now I will say 15 years later, he is being treated for his polycythemia vera and has had no other additional events, but he certainly slid into the practice in a very dangerous way and nearly died. So, as my brother would say, how do blood cells relate to cardiovascular disease, which is so much more important? And I would say, well, how do blood cells relate to the risk of developing cardiovascular disease? And there's a very important sort of alliance between them. And it's nice that it came right after an inflammation discussion, because inflammation, I think, plays a really key role in the sort of talk between hematologic and cardiovascular disease. So this is just basic anatomy in case you have forgotten from grade school or from high school how it all works, that deoxygenated blood comes through your inferior vena cava, which flows unoxygenated into your right atrium of the heart and into your right ventricle. And your right ventricle then pumps that deoxygenated blood through a very low pressure pathway through all of the pulmonary vasculature, where that deoxygenated blood becomes oxygenated again. And that blood then flows through the pulmonary artery into the left side of the heart, where it's oxygenated, flows into the left ventricle, where it is pumped with magnificent force through your aorta, and that oxygenated blood flows through all of your system and oxygenates all of your tissues. So that's kind of how the normal plumbing works. And of course, that normal plumbing depends on blood cells, which are in the blood, which are, the red blood cells in particular, are incredibly important in picking up that oxygen, holding on to it, and carrying it to the appropriate tissues. I will not quiz you on that. But what can go wrong in this really big picture? So anything that interferes with the heart's ability to pump blood. So if the heart muscle is not working well and it can't pump, then oxygenated blood is not going to flow appropriately to tissues. Anything which clogs the arteries or veins so that blood can't flow. So if the blood becomes too thick to flow normally, that's going to interfere with the ability of blood to oxygenate the tissues. And anything that interferes with the ability of oxygen to actually be released from the red blood cell and diffuse from the lungs into the pulmonary veins, that's another, either from the red cells into the tissues, or in the sense of deoxygenated blood, the oxygen from the lung coming to the red cell. Anything that interferes in that process can cause an inability to properly oxygenate the tissues. So what exactly is a heart attack? So a heart attack is something that generally occurs in older people, and these older people generally have a problem in their arteries in the heart, and that is that they have atherosclerosis and they develop plaques. And that yellow stuff in that picture is atherosclerosis, which is really sort of a combination of platelet aggregates and fat and fibrosis that actually narrow the arteries and make them less elastic. So they can't expand and contract as well as they would if they didn't have atherosclerotic disease. So you can imagine if you were to develop a blood clot in a very, very narrowed vessel, that there can be no blood flow through that, and that's how you develop a heart attack. So a heart attack is really a blood clot in an artery in a vessel where there's no blood that can flow. So the tissue around it is not getting oxygenated blood, and that tissue dies. So that's what a heart attack is. So if you look closely at the interactions, what happens when we look closely at the interactions between blood and the risk of cardiovascular disease? So in normal people who don't have MPNs, the risk of cardiovascular disease is related primarily to age. So the older you are, the higher the risk of the development of cardiovascular disease, which you cannot change as of yet. Family history. Do people in your family have a risk of developing cardiovascular disease or have a risk at younger ages? Elevated cholesterol level, hypertension, the presence of a metabolic syndrome, a pre-diabetes or diabetes, a sedentary lifestyle, smoking. But there are some people who are able to modify as many of their cardiac risk factors as they can and have a low risk for cardiovascular disease, but yet they develop an MI or a heart attack or a stroke. So why does that happen? There are other diseases which are associated with cardiovascular disease: rheumatoid arthritis, lupus, chronic kidney disease, recurrent infections, diabetes, myeloproliferative diseases. The link between these diseases is really an overactive immune system or inflammation, and that can play a really primary role in developing a heart attack or a stroke. What links cardiovascular risks and inflammation in normal patients? And the answer is really the composition of the blood, which includes the cells in the blood, but also these cytokines, which Dr. Fleshman talked about so nicely before, that are also in the blood and basically orchestrate how the blood cells are going to behave. It's a very complicated symphony, if you will. An elevated white blood cell count, which can be caused by cytokines and can be caused by immunological excitement, has been associated with the risk of cardiovascular disease after the adjustment for any other cardiac risk factor, such as age, body mass index, and your lipids. Monocytes and neutrophils and platelets are strongly associated with the risk of cardiovascular disease when they are elevated. So atherosclerosis, which is that yellow stuff that I showed you that narrowed all of those vessels, is driven really by a combination of elevated lipids, cholesterol, and inflammation. Interestingly, there was a cardiac study called the CONTO study that showed really that inflammation is a very important, if not the most important driver in the development of atherosclerotic cardiovascular disease. And in a study published in 2017 showed that by targeting inflammation with an antibody against interleukin-1 beta led to a lower incidence of cardiac events as compared to placebo. But of course, using immunosuppressive medication to prevent cardiovascular disease also is fraught with many risk factors for other problems. So the benefit of using anti-inflammatories generally to prevent cardiovascular disease did not really catch on. But it's interesting as a proof of principle that by really cutting off inflammation that you decrease cardiovascular disease. And interestingly, in animal studies recently, there has been shown to be a direct link between dyslipidemia and hematopoietic stem cell proliferation. So Gu and his colleagues showed a regulatory role for some of the cholesterol efflux pathways in the mobilization of hematopoietic stem cells from the bone marrow. There's a gene, not that this gene is important, and again, I won't quiz you on it, but it's kind of interesting, SREB2, which is important in cholesterol efflux regulation, also is important through Notch signaling, which helps control hematopoietic stem cell homeostasis. So cholesterol metabolism and inflammation are directly interconnected through this transcription factor, SREB2, in animal studies. And these were done in zebrafish and in mice. And so this is just interesting to think about, actually, that there is potentially a crosstalk between cholesterol metabolism and the hematopoietic stem cell mobilization. And to think that, potentially, this is a complicated picture looking at all of this, that elevated cholesterol may have a stimulatory effect on the expansion of hematopoietic progenitor cells. And this would be in normal people, but if you have cells that have a special proliferation, like JAK2 positive cells, it's interesting to hypothesize that potentially things like elevated cholesterol could aggravate diseases like myeloproliferative disease. This has never been proven, and we've never really looked carefully in clinical trials at how modification of risk factors for cardiovascular disease may improve outcomes in myeloproliferative diseases, but I think it's a really important area of study, although maybe not so sexy for a lot of people. It's not surprising when you think of all of this that patients with MPNs have an increased risk of cardiovascular disease over patients even who have high risk factors potentially for cardiovascular disease. When you think there's an overproduction of red cells, white cells, and platelets with increased viscosity in the blood, which means as that blood is running through the plumbing, it's running very, very slowly potentially. It doesn't flow through the vessels like it should, so it's much more likely to develop a clot or a slowing in the circulation. It's very clear in looking at studies that there's an abnormality between the interaction of MPN, for example, JAK2 positive cells, and the cells that line the vessels. So that interaction also may make an MPN patient more prone to develop a blood clot. And this increased production of cytokines that inflame the immune system in the setting of having all of these cells and that are potentially not running smoothly through the plumbing also increases the risk of developing blood clots and vascular injury. So what we worry about a lot when we first meet MPN patients is the risk of thrombosis, because it is the leading cause of morbidity and mortality in MPN patients. And the mechanisms for increased risk for thrombosis include abnormalities in the MBN clone-derived blood cells and vascular cells that are lining the vessels. But we also have to think that cardiovascular risk factors, together with these, play a really important role and probably increase the risk of cardiovascular disease or thrombosis or stroke or venous thrombosis in these patients. And these are just pictures, in case you haven't seen them, to look at what an arterial thrombosis looks like in cross-sectioning. You can see that that artery, which should be very pliable, it should be able to expand and contract, is full of stuff, and that's clot and atherosclerotic disease. You see a venous thrombosis picture, which is quite exaggerated, where you see a leg which is really erythematous, which means red, and quite swollen. And you also can see microcirculatory disturbances in the last picture, where you can see that patients have fingertips, for example, that are red or purple, or that looks, when you look at the hands, like blood is not flowing normally. That might not be an artery or a vein per se, but the small vessels that sort of connect the arteries and veins and deliver oxygen to the tissues. So the pathogenesis of thrombophobia in MPNs is really an interaction between the tumor-mutated clone and your response to that tumor-mutated clone, so that when you have circulating malignant cells, your host response to that may be sort of an inflammatory response with production of cytokines and a raise in inflammatory stimuli, which is prothrombotic. and activates not just the malignant cells, but your non-malignant cells to participate in the development of a blood clot. There are also studies to suggest, and it might not be the number of platelets that are so important, for example, in ET that causes the development of blood clot, but in what the qualitative ability of these platelets are to clot. So little microplatelets that find their way into the circulation, increases in things like p-selectins, which are inflammatory particles, may increase the risk of developing a blood clot. It may be the qualitative function of those platelets, not the absolute number, which is important. Patients who have thrombosis, who are MPN patients, tend to have recurrent thrombosis. There was a paper on leukemia in 2016 evaluating the reoccurrence of thrombosis in MPN patients. And they saw in about 700 patients, 45 recurrences, 36 of them venous, with an incidence of 6.5 per 100 patient years. In those patients who received Coumadin or warfarin, the risk of recurrence was much, much lower than those who did not receive warfarin, pointing once again to the importance that in patients who have MPNs and who develop blood clots, that they may need long-term anticoagulation. There have been remarkably few studies looking at MI or a heart attack as a complication of PV and ET. And it's surprising that there has been so little really looked at. This is a small patient study that I looked at, which was purely retrospective, which showed that out of about 250 patients, 60 patients, 14 patients had an MI during the period of follow-up, which was only about 2 years. And the clinical, there were 14 MIs, and that the cardiovascular disease risk factors in these patients were about 92% of patients had them. Most of the patients who had an MI had it within the first 12 months of diagnosis. But as I said, there was a very short follow-up to this paper, and it's something that I think we need a lot more data and looking prospectively at our patients with myeloproliferative disease and their rates of MI over time and with different therapies. It's in the last couple of years, one thing that has been rather exciting to look at is that in myeloproliferative diseases and myelodysplastic syndrome, we've realized that patients develop abnormalities or genetic abnormalities which are associated with these myeloid diseases. And a lot of these patients don't necessarily have a hematologic disease, but they have an abnormality in a gene which is related to myeloid development, and that these patients, these can be common in older patients. If I went out on 2nd Avenue in New York City and decided to test every single person over 50, I would find a large percentage of these patients might have a gene which is abnormal but have no hematologic disease, although these genes may be associated with the development of hematologic diseases in the future. But there was a paper in the New England Journal in 2017 looking at patients who had these sorts of mutations and finding that they had an association with the development of cardiovascular disease. This is just a graph really looking at the number of mutations that patients get, which are abnormal, and it's related basically to age. You can see when you're 20 and 30 and 40, you have very few abnormal mutations. That's because you're young and your cells haven't divided that much, and there's nothing that's really happening to these cells. But as you get into your 50s and your 60s and your 70s and your 80s, there's an increase in the number of people who develop abnormal somatic mutations. And these may not be related to disease at all, just to the number of times your cells have divided. And I point your attention to the left-handed upper area of this graph here, which shows you the different genes which tend to be mutated in the patients that were looked at in this particular study. And the one that was most prevalent was one called DMT3A, which you also can see in patients who have myeloproliferative diseases that are relatively advanced. But as a single mutation, it probably doesn't mean very much in an older patient. But you can see that a percentage of the patients that were studied on this trial also had JAK2 mutations. And so there were patients included on this particular study who were JAK2 positive. And if you look at the effect of having these somatic mutations, any of them, on all-cause mortality, the patients who happened to have them had a worse overall survival than those patients who didn't. And this is mainly was related to the development of cardiovascular disease. So there is a causal relationship of these CHIP mutations to the development of cardiovascular disease. And there's abundant evidence of a link between JAK2 positive mutations and cardiovascular disease. And this is presumably because of a link between higher blood counts. But more research needs to be done as to what are all the other aspects of having these mutations that can cause a risk of cardiovascular disease. Is there more than just the proliferative nature of, for example, JAK2 positive patients? TET2 positive mutations in causal studies, also mainly in mice, where there are pro-inflammatory cytokines, and there's increased secretion of things like interleukin-1b and monocyte activation, also had increases in atherosclerotic plaques. So there's a lot of research actually now being done in the cardiovascular community mainly, maybe down at the Cleveland Clinic vascular study, which is either upstairs or downstairs. They're talking about this as to what are the mechanisms that cause these patients with these mutations to have higher risks of cardiovascular disease. And what is this marker actually telling us? And certainly, what is the relationship between having this particular problem in the blood and the development of cardiovascular disease and potentially earlier mortality in these patients? So I think this is an exciting intersection of hematology and of cardiology, and I think is sort of the beginning of genetic medicine as we try to figure out, when you have particular mutations, what does this mean to all different sorts of organ systems. I don't know if anyone's read Yuval Harari's 21 Lessons for the 21st Century. But if you haven't, it's an interesting read, and one of the things he talks about is that as we learn more about genetic medicine, that all of us will be sick, that we're all going to have testing, and we're all going to have genes which are abnormal, and we are sick, and we're going to have the diagnosis of an illness. And we're all going to have to learn in the 21st century how to negotiate the fact we have an illness, we have a gene which is not performing correctly, and we have a risk of developing something, and how we're going to negotiate that in the 21st century. So I just say that as food for thought, and that's what this is really meant for, because we don't really have a mechanism outlined to connect how this all works out. I'm now shifting gears a little bit from heart attacks and sort of the mechanism of stroke to heart failure in myeloproliferative diseases and its relationship to pulmonary hypertension. And I became interested in this just because, for various reasons, my MPN patients end up getting echocardiograms, either because they've gone to the emergency room or their primary care doctor has gotten one or they see a cardiologist. And I was noting that a lot of my patients tend to have pulmonary hypertension just incidentally on their echocardiogram. So pulmonary hypertension, what is that? So you may remember when I showed you the schema of the unoxygenated blood that came into the right ventricle, and it's then pumped into the lungs and then comes back into the left ventricle. That system where it's pumped from the right side to the left side is a very low pressure system. So that blood should flow through that very easily and get oxygenated and come back to the left side of the heart. But pulmonary hypertension is when there ends up being high blood pressure in that lung vasculature. So when the right heart is pumping, it's really, really hard for that right heart to get that blood to pump all the way through and get oxygenated and come to the left side. And that's abnormal, and that's called pulmonary hypertension. And when someone takes your blood pressure, they're not measuring your pulmonary blood pressure. They're only measuring your systemic blood pressure. It's much harder to measure your pulmonary blood pressure. And the blood pressure in your lung is very, very low. It's about 1/5 of your normal systemic blood pressure. And there are many, many disease processes which can cause pulmonary blood pressure to rise. Anything that would cause vasoconstriction in the pulmonary vasculature, or where something has happened to the pulmonary vessel wall where it's become very thick, or if you have a big blood clot that occurs at any point during and through that pulmonary vasculature, that can cause high blood pressure. So at Cornell, we decided to do a study of all of our MPN patients and pulmonary hypertension. And it was a joint effort between the cardiology and hematology faculty at Cornell. We looked at 303 patients who had a mean age of about 70, and about 48% were male, and they all had MPNs. They were not broken out for ET, PV, or myelofibrosis. But a stunning 56% of them had pulmonary hypertension. And these patients reported to various physicians in our electronic health record as having a higher rate of dyspnea and fatigue. And looking at a median follow-up of these patients from their first echo of 6.3 years, overall survival of the MPN pulmonary hypertension patients was nearly 10 years shorter than the non-pulmonary hypertension patients who had MPNs. And doing multivariate modeling, including age, gender, diagnostic risk group, leukemia transformation, and stem cell transplant, advanced pulmonary hypertension independently conferred a twofold increase in the risk of death. And patients with pulmonary hypertension had increased a left ventricular mass, so it was thicker. They had something called left ventricular diastolic dysfunction, so it didn't relax enough to let the blood flow through easily, and increased left atrial size, suggesting that it was post-capillary, very small vessel processes that contributed to the mechanism of pulmonary hypertension in patients who have MPNs. And this study really showed that pulmonary hypertension is highly prevalent in MPN patients and associated with common clinical symptoms in MPN patients that were sort of crossover sometimes with the MPN itself, such as fatigue, and it was independently linked to increased mortality. We're now embarking on a prospective study looking at patients with MPNs and doing rather technically difficult echoes to evaluate pulmonary hypertension from a perspective standpoint and to get a better understanding of what the mechanism is for this disease. So in summary, really there are important new relationships that are being found between blood cells and the development of cardiovascular risk. The new link of clonal hematopoiesis to higher all-cause mortality and the link to cardiovascular risk is really interesting. And there's going to be a flurry of research looking at the specific causal reasons for these individual mutations to have a link to cardiovascular disease. MPN by itself is a major risk for thrombosis, MI, stroke, and pulmonary hypertension, which is really going to drive, I think, a new field looking at the relationships between germline and somatic mutations and the development of cardiovascular risk and pulmonary hypertension. I think this will be the beginning of that new wave of sort of, a more comprehensive genetic look at who you are and what the risks are for the different diseases that you may develop through time. It's that transition to us all being sick instead of all being well people. And it may point the way for new treatments for MPN patients, maybe modifying, for example, a lipid metabolism may itself be an anti-inflammatory treatment that would improve myeloproliferative disease symptoms and outcomes. And for me, I think it's important to really start looking much more closely at what the result would be of tightly controlling other cardiac risk factors to decrease cardiovascular events in patients with MPNs, which has never really been specifically looked at in large groups of MPN patients because it's not really treatments. It's not going to lead to the development of a new drug, just the development of a new type of practice. So new research is really needed, prospective studies on the relationship of somatic mutations and on aging blood cells to the development of cardiovascular disease, studies on the control of cardiac risk factors and the outcome of MPN patients, prospective studies on the development of pulmonary arterial hypertension in MPN patients, and would early treatment of PV and ET decrease the risk of pulmonary hypertension? We don't generally treat patients with medications that may lower their blood counts if we don't think they need them or change their symptoms because there's not actually data for that. But if we found that if we treated patients earlier, it may decrease the risk of pulmonary arterial hypertension, that might change our practice. And what are new molecular targets in cardiovascular disease patients and MPN patients in particular that might be important to modify to decrease risk? What can you do to decrease your overall cardiac risk? And that is to manage your cardiac risk factors, to eat a heart-healthy diet, probably best to be low in cholesterol. As you have heard before, there's a lot of discussion about what the appropriate diet might be. Certainly the Mediterranean diet is attractive because it's easier to adhere to than many other diets. So we look forward to Dr. Fleischman's final sort of information as to whether that was superior. To take medication if your blood pressure is elevated, don't wait around and see what's going to happen to you. Do not lead a sedentary lifestyle, and to develop a regular exercise program. We've heard in this program so far that one of the only things we've seen that can battle fatigue is regular exercise. So even though you might be tired, it's worthwhile to try and get yourself involved in a regular exercise program. Be that yoga, spin, taking a brisk walk every day. You can choose what it is, but you should start and try and do it. Manage your MPN with your physician. The goal is to manage your blood counts and if they can, your inflammation. So discuss this with your MPN doctor and discuss it openly. Tell them what your symptoms are. Do not hold back. And participate in clinical trials, please, to help us learn more about the relationships of MPN to cardiac risk and to how we can better treat MPN patients to improve their outcomes. And I think that's it. If anyone wants to get in touch with me ever, you can find me at ritchie@med.cornell.edu. And thank you very much for your attention.